I'm going to talk about some of the more common causes of headache, some of the rarer causes but important ones which you should be aware of, and the clinical features of some of these and how to investigate and manage them. Now, headache is probably the most common outpatient neurological presenting complaint. Now, in terms of neurology outpatients, probably not so much, but certainly in primary care, it's one of the most common presenting complaints. And for the vast majority of patients in the outpatient setting, headache isn't usually associated with any serious underlying neurological pathology. However, occasionally it is, and that's why it's very important when you see patients with headache to take a clear and focused history, because almost always the underlying diagnosis is made on the history and not on the examination and investigations. So what are the commonest causes of headache? Well, by far the most common cause is tension-type headache. And this is a sort of common or garden headache, which people get from time to time. Migraine is also extremely common. Slightly less common, things like sinusitis, and then, of course, having a headache as part of a systemic infection. Neurological infection, I won't go into just yet because I'm going to be talking about meningitis a bit later. And then it goes without saying, obviously, that trauma, if you have a head injury, you're going to have a headache after that. And then occasionally some drugs as well. And one example would be GTN. One of the side effects of GTN spray is a headache because of the vasodilatation. So these are some of the more rare causes of headache, and I've highlighted the first two as important ones which I'm going to cover, as these can be life-threatening. Well, certainly subarachnoid hemorrhage and giant cell arteritis can be sight-threatening. So I'll come on to those in a bit more detail later. Other causes which are rarer, things like space-occupying lesion. Of course, this is what the patient is most worried about. Someone who comes in with a severe headache, often they'll wonder, have I got some kind of tumor or something? But actually, it's quite a rare cause of headache, but important to keep in mind. Or other space-occupying lesions like a cerebral abscess or arteriovenous malformation. After stroke, headache is quite a common symptom, which can be quite troublesome, actually, in the initial stages. Cluster headache can be very debilitating. It's characterized, as the name suggests, by clusters of headaches which come in sort of 3s and 4s every few months, often in the middle of the night, and that they are severe headaches, usually unilateral, often around the orbit, and associated with things like sort of lacrimation. And they can be so severe that they can drive patients actually to consider suicide. It can be very difficult to manage. Neuralgia, for example, trigeminal neuralgia, is headache caused by problems with the nerves. Medication overuse, and this can be quite difficult to tease out, actually, because obviously if someone who has headache, they'll be taking analgesic medication in order to relieve it, but sometimes overuse of paracetamol can actually exacerbate headache. When the patient stops taking the medication, the headache gets worse. So how do you approach someone who presents with a headache? Well, as I mentioned earlier, taking the history is key. You need to know the onset and progression of the headache and how long it lasts, because that is the best way to try and determine what kind of headache it is. And then whether these are recurrent episodes or whether this is a new problem. The site of the headache. Certain types of headache are unilateral. For example, migraine is often unilateral, as are cluster headaches, whereas tension-type headaches tend to be more generalized. And then if there are any other associated symptoms, for example, aura before a migraine. I'll come on to that a bit more when I talk about migraine. And if there's anything which precipitates it or relieves it. Now, tension-type headache. probably the most common cause of headache in the outpatient setting. What causes tension-type headache? Well, actually, it's not entirely clear what is going on, but I think the general consensus is that it's muscular pain, so problems with the connective tissue and muscle in the scalp and the neck. And as you can imagine, it's very common. Lifetime incidence is 70 to 90%. Now, when you're taking the history, the key point, as I said earlier, is to try and work out the onset and progression. Tension-type headaches tend to last for quite a long time. It could be a few hours or sometimes even days. The frequency can vary according to the severity. Sometimes it can be quite infrequent, and occasionally the patient will present saying they constantly have headache, and it can be quite debilitating. And they'll describe having just a sort of dull, aching headache, which just won't go away. It's associated with stress, and usually there are no other physical symptoms. It's just isolated headaches. And the management is really to try and reduce the precipitating factors, reduce stress, and simple analgesics in the first case. Now, migraine, I'll spend a bit more time on. Migraine is caused by vascular process going on in the brain. Exactly what happens, it involves altered neurochemical activity. I won't go into the details, but it involves serotonergic receptors, and you get vascular spasm, which causes headache, and sometimes that vascular spasm can also cause other focal neurological symptoms, which I will come on to later. It's relatively common, lifetime incidence of 5 to 10%, and the peak onset is in early adult life. And it can be broken down into 3 different types of migraine. Simple migraine, which is just the headache, a migraine without an aura. The classical migraine, where the patient gets an aura, and I'll explain what that is in a moment, before they get the headache. And then acephalic migraine, where the patient doesn't actually get headache, but does have the symptoms of the aura beforehand. So what exactly is this aura? Well, it's these sort of neurological symptoms which occur, and the patient knows when they get these symptoms that they're going to end up having a migraine, a headache afterwards. And often they're characterized by odd visual disturbances like flashing lights, fortification spectra, which look like sort of zigzag lines going across the visual field. Scintillating scotoma is a visual field defect. So a patient will describe sort of blotches in their vision, often in the central part of the vision, which come and go. And then occasionally you can get peripheral focal neurology, sensory disturbance like numbness or tingling, or motor disturbance. The headache itself, often unilateral, not always, but characteristically unilateral headache. And as well as the aura and the headache, the patient might have nausea and vomiting, and they might have photophobia as well. And typically the duration can be anything from a few hours to actually, in severe cases, up to 2 days. Now, migraine can be debilitating, and some patients will describe, and you'll see if the patient has got very debilitating migraine, that if it happens, they have to stop whatever they're doing, go and find a quiet, dark room and take a little while to recover. It can be quite debilitating. What are the precipitating factors? Well, there's several really, and they all contribute together. So often it's not just one thing, but a combination of things. It might be dietary, and you might want to see if take an alcohol history. Occasionally people link it to things like sort of chocolate and cheese consumption, but not necessarily. It can be related to taking the pill, and then stress as well, fatigue or sleep deprivation. Management, as in all problems in clinical medicine, always start by trying to look at reducing the etiology, so trying to reduce the precipitating factors. And then going on to further pharmacological management, well, there's two areas you want to look at. First of all, trying to prevent the patient getting any attacks of migraine, and then something which they can take if they happen to get an attack. So preventative, the first line is a beta blocker, for example, propranolol. And if that doesn't work, then you can consider a serotonin antagonist like pizotifen. During an attack, paracetamol and non-steroidal anti-inflammatory drugs to try and reduce the pain, analgesics, antiemetics if the patient often gets nausea and vomiting during episodes of migraine. And if those fail, then the triptans, and these are selective serotonin receptor agonists, 5-HT1 receptor agonists, and in very difficult cases, then steroids may be of help, but that's contentious. Now, I mentioned earlier that you can get these subtypes of migraine which actually have focal neurology, and in a way, these are sort of on a spectrum between migraine and actually vascular cerebral disease, because you get vasospasm in certain areas of the brain, and depending on which part of the brain is affected, that results in the focal neurology. So basilar migraines, which affect the vertebrobasilar circulation, typically result in symptoms like visual disturbance, dysarthria, difficulty speaking, vertigo, paresthesia, and paresis. Whereas in the anterior circulation, you may get hemiplegic migraine with focal neurology on one side. And sometimes it can be difficult to establish whether this is actually a stroke or a TIA. It can be quite difficult. And then more rarely you can get more specific problems like ophthalmoplegic affecting the eye movements, and then retinal affecting the blood supply to the retina. Now, moving on to subarachnoid hemorrhage. This is a rarer cause of headache, but extremely important. It's caused by bleeding into the subarachnoid space inside the skull. And there's three main causes for subarachnoid hemorrhage. The first is a ruptured aneurysm, typically a berry aneurysm in the posterior circulation of the circle of Willis. And the patient will usually not know about this. They'll be completely asymptomatic, and then suddenly the aneurysm will rupture and they'll have a subarachnoid hemorrhage. It may also be caused by bleeding from an arteriovenous malformation, and it goes without saying, trauma, direct trauma to the blood vessels causing bleeding. Now, the key here is the onset. It's sudden onset. In a matter of seconds like that, the patient will have a very severe headache, and it's characteristically described as the thunderclap headache. It feels like you've been hit by lightning. Patient will also have photophobia and meningism, because of the irritation to the meninges as a result of the blood within the subarachnoid space. They may also have nausea and vomiting and signs of raised intracranial pressure. Now, how do you go on to investigate someone with subarachnoid hemorrhage? Well, first of all, obviously, when you see the patient in the emergency department, you have to resuscitate them, make sure they've got oxygen, venous access. Do some routine blood tests for blood count, Usinese, and a coagulation screen in case the patient has bleeding diathesis. And then a CT scan is extremely sensitive for acute hemorrhage. However, occasionally in very acute subarachnoid hemorrhage, small subarachnoid hemorrhage, you may not pick it up, and you may need to have subsequent lumbar puncture 12 hours later, which is almost always diagnostic. And in lumbar puncture, you are looking for xanthochromia. And if you wait after 12 hours and the patient has xanthochromia, that's pretty much diagnostic for subarachnoid hemorrhage. After doing the CT scan, you can go on to do subsequent angiography, either CT or magnetic resonance angiography, to try and work out which part of the blood supply is affected. Here is a CT scan illustrating quite a severe subarachnoid hemorrhage. And on a CT scan, fresh blood in the skull, in the brain, is white. So you can see here all the subarachnoid spaces in this scan are filled with blood. Now, from this scan, it's not particularly easy to determine exactly which vessel is the one which the bleeding has occurred from, because there is just so much sort of bleeding. It's quite difficult to tell. So you would need to do further imaging in order to determine that. As I mentioned earlier, initial management, as with all medical emergencies, stabilize and resuscitate the patient. And if the patient has a low GCS, they will need a definitive airway, and by that I mean an endotracheal tube. So if the patient has either a dropping GCS, their GCS is reducing, or they come in with GCS of less than 9, you must consider definitive airway. Analgesia and antiemetics and calcium channel antagonists are thought to help in reducing vasospasm after spontaneous subarachnoid hemorrhage, although note that there is no benefit if the hemorrhage is caused by trauma. Now, further management of a subarachnoid hemorrhage caused by a ruptured aneurysm may involve one of two options, either endovascular coiling or surgical clipping. Now, this is an example of an angiogram showing aneurysm in the left vertebral artery. Before the patient has had surgical clipping, you can see this area here, and then afterwards. So a clip is placed at the base of the aneurysm in order to tie off the base. The other alternative is endovascular coiling, and that involves passing a catheter through the femoral artery up into whichever the affected blood vessel is, and using an endovascular coil in order to fill the space where the aneurysm is, in order to block it off. Now, there's a very influential study done quite recently looking at the benefits of coiling versus clipping, the ISAT trial, and this is really just for interest. Someone asked you the sort of relative benefits of the two. And this looked at patients who had spontaneous subarachnoid hemorrhage as a result of aneurysm rupture. And it found actually that coiling was associated with a significantly lower one-year mortality than clipping. So currently, coiling is the preferred technique. Now, the other important cause of headache, which I just want to touch on, is giant cell arteritis. And the reason for this is because this can result in irreversible visual loss. It's also known as temporal arteritis, and it is caused by vasculitis, affecting medium to large vessels. Now, giant cell arteritis is predominantly a disease affecting the elderly. And I would say that if you've got someone who's less than 50 years old presenting with a headache, it is extremely unlikely to be giant cell arteritis. It really only affects people who are elderly. The clinical features, well, severe throbbing headache, but the key here is that it affects the temporal artery. So the patient will be tender over the scalp, over the temporal artery, and when you palpate it, it'll be non-pulsatile. The patient may also complain, if you ask them on direct questioning, of pain which worsens on chewing or talking and using the muscles of mastication, also known as jaw claudication, because those muscles are supplied by that artery. And the patient may also complain of visual loss, and this is very important to pick up because it may be irreversible. Now, the key investigation initially is to look at the ESR. Usually, but not always, the ESR will be raised. The patient can still have giant cell arteritis with a normal ESR, but if they have a raised ESR, then that's quite suspicious. And then you also want to look at the full blood count to look at the level of platelets and the hemoglobin. Occasionally a raised alk-phos, but it's not sensitive or specific. Temporal artery biopsy can confirm the diagnosis. However, the management does not depend on having a positive biopsy result, and you would treat the patient empirically with urgent IV steroids, so you wouldn't wait for a biopsy result. This is a slide showing microscopic section through the temporal artery of someone who has temporal arteritis. And you can see here the lumen of the blood vessel is just full of these inflammatory cells which are blocking the lumen. And this is typical of what happens at microscopic level in temporal arteritis. So to summarize then, the two most important common causes of headache are tension-type headache and migraine. And rarer but important to consider are subarachnoid hemorrhage and giant cell arteritis. And the key to approaching someone who presents with headache is taking a focused, clear history, looking at the onset and progression, and whether these are recurrent episodes or new onset, the site of the headache, any associated symptoms, and precipitating and relieving factors.